Welcome to Pharmacotherapy Innovations, a game changer in obesity management. Hello, I'm Bob Kushner. I'm a professor of medicine and medical education at Northwestern University Feinberg School of Medicine in Chicago, Illinois. And today I'm joined by Dr. Debbie Horn, who is medical director at the University of Texas Center for Obesity Medicine and Metabolic Performance and program director for their fellowship in clinical obesity medicine. Welcome, Debbie.
Hi, Bob. Thanks for having me.
I am very excited about this podcast with you today because you are not only an experienced obesity medicine clinician, but also an investigator in many of the phase 3 trials that are conducted with the new and emerging medications. So today we're going to discuss topics related to the latest clinical evidence for the pharmacologic management of people with overweight or obesity. So Debbie, I want you to start today by providing an overview of the current guideline recommended goals for pharmacologic management of these patients. Like, what criteria should clinicians use to determine when to initiate pharmacotherapy?
Of course, this is one place where our spectrum of guidelines are pretty consistent because it's set predominantly by the FDA. So to start an anti-obesity medication, an individual should have a BMI greater than 30 or a BMI greater than 27 with at least one obesity-related comorbidity. Now, I would say the caveat to that that's an interesting development lately is not only are we finding that we need slightly adjusted changes for different race populations based on their body fat and their visceral fat, but also more interestingly, I think one of the latest labels to change for semaglutide actually not only included cardiovascular risk reduction, but actually changed the definition for starting an anti-obesity medicine to just saying the patient needs to have obesity and or overweight with a comorbidity and not necessarily putting a BMI number on it. And I think that helps all of us as we think towards the future, what is our best target for these patients who are struggling, and is BMI the right number or not? It allows us to think about individuals with sarcopenic obesity that might not meet that BMI criteria, but we might be thinking about. So while it's still very traditionally BMI cutoffs now, I think it will continue to progress over the next couple of years.
Yeah, Debbie, I'm so glad you brought that up. That's been very subtle, I think, really under the wire of most people being aware of that product label change. We're aware because we do this all the time, but that is really important. I think that's more to follow as more health benefits these medications become apparent.
I agree. And I think we sort of have to look at both sides of that. I'm a glass half full kind of girl, so I thought it is very positive for us being able to open up that definition a little bit. A colleague quickly shared with me that I also have to think about the fact that allows other stakeholders to define that as well, potentially insurers and employers. So there's a lot that may change on that over the next couple of years.
Yeah. I also know that you came up with a clever 5 C's mnemonic for decision-making when it comes to choosing which medication to prescribe. And you published that, of course, in Postgrad Medicine in 2022. So Deb, what are the 5 C's and how can clinicians use them when starting a medication?
Sure. So I thought about the 5 C's when I was thinking about how to teach fellows how to effectively and efficiently make decisions with their patients during a visit. I defined it as 1, starting with contraindications. So first, do no harm. Are there things that the patient has on their disease state list already that would take any medications off the list? And that's actually easily done on an intake form, so you can even minimize some of the conversation about it. The second is comorbidities. Where can we get double duty out of our medications? So, for example, maybe a patient struggling with obesity and glucose dysregulation, whether that's insulin resistance or diabetes. Maybe you think about a GLP-1 for obesity medicine for them. What if a patient has a long history of migraines and they have obesity? Maybe we think about an anti-obesity medication that has topiramate inside it. And you can see how you can marry those things together. The third C is cues, and cues can mean several different things. It's not just what the patient might prefer, like mode of delivery. Am I okay with an injectable? Do I prefer a pill? What history do I have perhaps around side effects I've had with medications before that might guide us in one direction or another? But also, once you start the medication, what feedback do you get from the patient? Are they feeling symptom resolution? Is it efficacious for them in terms of our targets? And also, are there side effects that aren't resolving or getting better? And maybe we need to think about a difference. Number 4 in the C's is combinations. And that's not just lifestyle plus medicine or lifestyle plus surgery or medicine plus surgery. It's also thinking about this as a progressive disease. And like many of our chronic progressive diseases, in some patients going to require polypharmacy. So while we're still learning about how best to do that, combining some medications together to maybe get at different targets of mechanism of action. And the last C, which actually in my practice typically comes first, because I hate to talk about a medication that a patient cannot access or afford, is cost and coverage. And so as we know, it's been a struggle with these medications to find the right balance between that with patients. And so having that discussion early, oftentimes we ask our patients to actually call their insurance company to try to get some guidance on that before we even start the conversation. That way we're really talking about medication that they can access.
Right. 5 Cs. That's a great mnemonic for people to think about getting started with medication. Let's go to the other end of medication use, and that is the weight recurrence that may occur when you stop the medication. So we know from the semaglutide tirzepatide trials, if you suddenly stop the medication, weight often goes back. But do you know of any real world data or long-term data? What happens to patients? Is it going to occur with all patients? And lastly, how do we mitigate against that? How do we help patients maintain their weight loss?
Yes. So as you mentioned, we have trials that show us if you stop the medication, the average of the trial subjects regain weight, but that doesn't necessarily speak to the individual person. We're starting to see some real world evidence, but I think it needs to be a little more structured for us to really put value into it. Some of the original data coming out seems to have some flaws. I think we're learning in a clinical based real world way as employers change their minds about covering anti-obesity medications, what's happening with patients. And that's certainly sort of anecdotal in our clinical minds. But I think one of the interesting trials that's ongoing now to try to get a better sense of that is a trial that's looking at tirzepatide with patients open label on the medication for a year. That trial is getting ready to now randomize to patients either staying on a max tolerated dose, which is 10 or 15 milligrams, getting lowered to 5 milligrams, or a third of patients going on placebo. And we're hoping that that trial in a more structured way will give us some real guidance on who can manage that and who cannot. In the meantime, I think the most effective thing that we can do if a patient wants to try getting off medication, or if they're potentially going to lose coverage for the medication that they're on, is to see, can we slowly dose escalate the medication in the same way that we escalated the medication? Not because there's side effects that need to be mitigated from a side effect profile from the medicine, but seeing if their physiology can handle it as we go down further in the medication. Do they start to regain weight? Do symptoms start to come back? And that can also really help patients understand how these medicines are supporting their physiology, and that it's not just appetite control.
Mm-hmm. Yeah, I don't know about you, Deb, but I'm convinced there are people who can keep their weight off of medication. The reason I say that is because many studies were conducted from a behavioral treatment point of view, where people like look ahead, where 40% of those that lost 10% of body weight kept their weight off 4 years later. It's not a lifetime. But those people are there. I just don't know who they are. And I guess that speaks to following people closely if you're going to stop the medication so that you can identify those that will do well and those you have to intervene with at an earlier point of time.
Yeah, I agree. I think the Look Ahead trial was a special trial with a very intense intervention, though. And trying to afford that in our healthcare system or in people's lives might be challenging. I think the more common numbers that we see are about 5 to 15% of people can keep weight off long-term at the 5-year mark. And I think it's important to find out who those people are, because as always, we want people on as little medication as possible in their lives.
I agree completely. You talked about down dosing the medication in the trial you're doing, which is going to be a great, can't wait for those outcomes when they come in. But, because of these shortages that are occurring, or change of jobs where people lose coverage, they often say, can I go from drug A to drug B? Both are given once a week, the highly effective medications. What do we know about changing from one dose to another dose? Is there a rule of thumb? Is there an algorithm or equation we use, or is it more of the art of medicine when we go from, let's say, semaglutide to tirzepatide or backwards? Because people get in trouble, right? If you misjudge the dose, you can end up getting pretty sick.
Yes, that's very true. And I think for right now, at least because there are multiple medications in that GLP realm, it's really around the GLP conversation that we're having this. So we have a little bit of data that can help us, and that data is really around efficacy of medication. That data doesn't tell us about side effects at different doses. And so if you just look at the pure efficacy of the medication, if you're on an older drug like liraglutide, the top dose of liraglutide, 3.0 milligrams, looks like it gives about the same weight loss as about 1.0 milligrams of semaglutide. Now, more commonly, people are switching back and forth, as you said, between semaglutide and tirzepatide. And what we see in terms of weight loss or efficacy, the 2.4 max dose of semaglutide is about the same weight loss as 5 milligrams of tirzepatide. That still doesn't tell us about side effect profiles. And although side effects tend to be lower in percentages on tirzepatide, certainly patients can have one in either direction, switching either medications. So one of the things that we are practicing clinically and learning from our patients on now is having that conversation. If a patient had a lot of side effects, let's say going up on semaglutide, then we might start them at the bottom dose of tirzepatide and do a normal dose escalation. If they had almost no side effects or they were very mild and they're tolerating 2.4 without any side effects, then we really have a shared decision-making conversation with our patients about we could slide across to 5.0 milligrams. That's going to be the same efficacy. It gives us the best opportunity to minimize side effects. Or if we were on 5 milligrams of tirzepatide, we would be going up to 7.5. And if patients have no symptoms and they want to try that increased efficacy, we slide them up to the 7.5, letting them know there's an increased potential for side effects. So I think we're going to learn more and more about that in the future as well. But for right now, the data you can lean into is efficacy data, not yet side effect data. I will share there are 2 head-to-head trials going on right now. One tirzepatide head-to-head with semaglutide, and one tirzepatide head-to-head with a medication we don't even have yet, cagrilintide, which is semaglutide plus an amylin analog. And those 2 head-to-head trials will probably teach us a little bit more about the side effect profiles.
All right, good suggestions, and thanks for the heads up on the trials that are going on. Let's stick with these adverse side effects that you were mentioning. The GI side effects are well known. I think anyone who has treated more than one patient knows about these side effects, or gastrointestinal. And we talked about the importance of slowly escalating. You made that point, and that's very important. But what else should clinicians know to help our patients stay on these drugs, tolerate them better? What tricks can they use either through the MyChart or after visit summaries or those phone calls to really walk that patient through that dose escalation, tolerate the drug better?
Well, I think it starts at the time you actually prescribe the medication, when you're doing that decision-making together. So obviously verbally going over the most common side effects, but we all remember, even ourselves as patients, we only remember about 2 things that our doctor told us from any encounter. And so when you start adding a lot of information, we take that opportunity to give our patients a handout, both physically printed out in their after visit summary and located in their MyChart, of the things that we think are most important for them to know about the medication, how it's dose escalated, what those side effects might be, and how to mitigate them. And we encourage patients that if they're having trouble, if they're struggling with a side effect that is not improving over days or weeks, or is moderate to severe, to contact us through the portal so that we can help them mitigate those side effects if possible. Of course, in the long term, if a patient does not overcome a side effect and it's moderate or higher, it's really time to think about an alternative medication. But I would say start that conversation early. Give them a resource like your electronic medical record portal for finding that information again and letting them know how to contact you. The easiest way for us is for patients to send portal messages. And then we also have some standard protocols for our staff, our MAs, to help give feedback to the patients before it maybe even has to escalate to the provider.
What are the most common dietary recommendations do you go over with your patients to reduce those side effects?
You're very interesting. So with the GLP-1s, when we think about nausea, the first thing I talk to patients about is meal size. Because if you think about all of us eating a Thanksgiving dinner, we finish dinner, we are not hungry, we still choose to have pumpkin pie. That is our executive function choosing to override the appetite control that's already sending us messages that we're full. And if you're struggling with that already in your life in a day-to-day basis, sort of quantity of food intake, or we're trying to lower that quantity of food intake, not being attuned to that can really create some nausea. So I ask patients to think as they're eating their meals, stop about halfway through your normal meal as you're getting used to the medication and assess. Am I still hungry? How is my stomach feeling? It helps them sort of have a little cue point of when to reassess food intake. The other is, interestingly, not going too long between meals. More than 3 or 4 hours in some patients can trigger nausea, especially sometimes morning nausea. So they've gone all night without having had anything to eat. They might wake up nauseous. They might not be someone who's normally a breakfast eater. So we encourage them to try to have a little bit of something healthy for breakfast, and that usually quells the nausea. Also avoiding very high fat meals and very high simple sugar meals. All of those can sort of trigger a lot of these side effects. I haven't mentioned constipation much, which is also another pertinent side effect with these medications. So we really advise them in the beginning, at least 2 servings of healthy veggies every day, considering a fiber gummy or a non-sugar fiber source. And if they're willing, a probiotic, just to sort of optimize their GI tract while they're getting used to this.
Yeah, great tips. I'm going to add one more, and I'd like your feedback on this as well. And that's the timing of the medication administration. It's only given once a week. So you have to ask them, you're going to have, if you're going to have nausea at all or side effects, it's going to be the first 24 to 48 hours. So what do those 2 days look like? Do you want to do it on a Friday where you typically spend your weekend going out and being nauseated when you're with your friends eating out and trying new restaurants? Or do you want to take it on a Friday because you want more control of those weekends and remind you? So I always leave it up to the patient to say, you decide when you want to give it, Monday morning when you start the work week, or midweek, or at the end of the week. Do you have those conversations with them too?
I say the same thing, and I think it always, cuts the tension a little bit and gives them a little giggle when I say exactly what you said. Do you want to have the weekend to sort of get used to things, or you're the person who, I don't care how I feel at work, I'd rather enjoy my weekends, I'm going to start it on Monday morning, and then everyone chuckles a little bit. There's also the flip side of that I think is interesting from a side effect that we don't think about a lot, because it's not really a side effect, it's the mechanism of the action of the drug. And that is the last 2 days of the 7 days before they restart their medication, they're likely to have less hunger support. Because the half-life of these medications is 5 days, it's sort of waning off. Of course, we can't ask people to take a medication every 5 days. That would be mass chaos. And so I also ask them to think about, are there 2 days that are harder? Are the weekends harder from a sort of hunger control, craving control, food control standpoint? And if so, maybe Thursday or Friday is the best day to try to take your medication if you feel like you have more control of the work week, or the reverse. So keeping both of those things in mind, I think, helps them pick a good day of the week. The other thing I tell them is try to link it to something you can remember. Church is on Sunday morning, work is on Monday morning, poker night's on Thursday. I don't know what it is, but pick something to link it.
Yeah. The other thing I just recently, and of course, I know you're interested in exercise, is if you happen to be working with a personal trainer on a Tuesday morning, you may not want to take the medication Monday because you're going to be sick with the personal trainer who's pushing you, and you may not get hydrated enough and you may be nauseated. So there's all these variables. It gets more complicated the more we think about it, but it's all these variables we want to think about. So as a clinician, try to bring some of this to the patient, and they'll decide. Just before I get to the last question, which is kind of what's the future look like, and you're a researcher, and I think you're a great person to ask, but just before we get there, I'm going to hit you with another controversial hot button issue, and that is called compounding. So that is such a hot issue for the pharmacists, for patients, providers, insurance companies. What's the skinny? What's your bottom line on how professionals and patients should be thinking about using compounded pharmacies?
Sure. I think this is, number one, a very individualized decision, both for providers in what you're willing to do for your patients, and for patients in what they want to consider. Just so that it's sort of level set in case people don't understand. Compounding medications means a compounding pharmacy can formulate the medication themselves, not use the patented medication. It can happen when a patented drug is in short supply, and that's how it's happened this time with these medications. I think the concerns that we see raised are, one, we don't know where the active product is being sourced from, and we see so many different levels of concentration and dosing structure from pharmacy to pharmacy to pharmacy. It becomes very confusing for both providers and patients. I think some of the concerns we have is the FDA and a few of our state medical boards have issued some warnings. There have been serious adverse reported, and we don't have a full understanding of all of those. So we're still waiting to get some of that information. I do see patients that try it and have efficacy and some that don't, and that's no different than the patented medications as well. For myself, I think what I share with my patients is because I can't guarantee the safety and the efficacy of the medication, as a provider, I choose not to write compounding medication. But I do share with my patients that if they choose that, I still want them to share that with me, and I still want to help provide their care, because a lot of these scenarios with compounded medications aren't coming with comprehensive care. And I want to make sure the rest of everything they're receiving is good and that they're getting some monitoring around that as well. And that's where I am. I know some providers are choosing to write compounded medications. I don't feel comfortable with it without the safety data.
Yeah, I agree. That's a very informative and nuanced answer. It's not black and white, like don't use them or use them all the time. But it really falls on the shoulders of the provider and the patient to really know where that drug is coming from. And I agree. It's where's the active ingredient coming from and what are the good practices and quality assurance measures of that particular pharmacy. And I think that's a lot to ask for a provider and a patient to do that kind of research. So I guess buyer beware, but really know where you're getting that from. Deb, I want to wrap this up by having you put on your looking glass, kind of looking forward. And again, as I've already said several times, you're an active researcher. I think we both think it's a game changer. This really has changed the trajectory of obesity care. What are you looking for? What's exciting? What's getting on your list of looking forward to these drugs? And what could you anticipate over the next 5 to 10 years regarding pharmacotherapy?
Sure. Well, I just think the pipeline is really exciting. It's also going to teach us a lot. So, there's a beautiful paper that already demonstrates that there's at least 28 molecules being investigated on a GLP-1 backbone. So GLP-1 plus or GLP-1 plus plus. That could be things like GIP, like we see with tirzepatide, or glucagon, or other amylin analogs. And so I think we'll see a lot built on that backbone. Those medications that we have so far, that a few of them have been heading into phase 3 trials, look like they're going to have, if semaglutide is about 15% total body weight loss on average, tirzepatide is about 21. These are looking to be 25 to 30% total body weight loss. And I think that drives a really new, important question for us as providers in educating our patients. Some patients do not need 30% total body weight loss. And then we're going to have to learn together, do we have a set of choices of GLP-1s and we choose a less strong GLP-1 for patients who need to lose less weight, or do we do a lower dose of a more strong, more efficacious medication? Because what we also want to be careful about that we're seeing in the trials is some people get to too low of a body weight and too low of a BMI, because we, of course, know that weight and obesity and visceral fat is a J-shaped curve, and at too low or too high, your mortality goes up. So I think we'll see a lot of new decision-making around that. Some of the other exciting things are monoclonal antibodies. These work in a very different mechanism of action. And I think what's interesting about them is at least one of the ones that we have the most data on shows less weight loss, but almost purely fat loss with actual muscle gain. All of our other anti-obesity medications that I can think of now, we lose some muscle mass as we lose weight, just like we would with surgery or lifestyle intervention. This class of medications stands to really optimize that. And I think about that beautifully for someone who's at a lower BMI or a sarcopenic obesity definition, where I'm really only looking to change body composition and maybe not change weight to improve their health. And then there's many more things happening. I think one that I find interesting that is under investigation is a cannabinoid receptor antagonist. Again, we went through that in the 90s. It never got approved here in the US, but looking at a more receptor selective version of that to see if we can have a better outcome. And so I really get excited by how many different targets the scientists are thinking of. And it's really fun and interesting to watch it play out in our trials. And I look forward to some of them making it to clinical care.
Yeah, after so many decades of trying to find the right target, it's just amazing that this gut-brain axis really has cracked open our biologic approaches to treat obesity, and we're off to the races. We are so many medications to come. Deb, this was a fascinating, informative conversation. I'm sure our listeners agree. I want to thank you so much for joining and sharing your experience and your thoughts about pharmacotherapy.
Thank you, Bob.
And thank you all for listening to this podcast on pharmacologic management for treatment of obesity.